Good afternoon and welcome to Family Medicine Grand Rounds. For those who don't know me, I'm Mark Huntington. I'm the director of the Family Medicine Residency Program at the Center for Family Medicine and also professor in the department. It's my great privilege to be able to introduce today's speaker, Dr. Andrew Bazemore. Dr. Bazemore and I have known each other for a million years, and it's great to get him here to South Dakota for the first time. He is a actively practicing family physician, and he's also the director of the Robert Graham Center. For those who aren't familiar with it, the Robert Graham Center is the Academy of Family Physicians think tank in Washington. It looks a lot at data and helps guide policy by using evidence as a means of demonstrating the importance of primary care and family medicine. In addition to that, Dr. Bazemore has been very actively involved in global health and been in a variety of different countries, seen health systems in a variety of different places in addition to our own. He has over 150 peer-reviewed publications. Many of them are policy-related. Many are have to do with demographics and data regarding the provision of health care, and also a number of clinical topics as well. He got his MD at the University of North Carolina. He got his MPH from Harvard. He did his residency at the University of Cincinnati, which is where I met him. He currently holds faculty positions at Georgetown University, VCU, and George Washington University. He's active in teaching at the VCU Fairfax Family Medicine Residency Program. He's an elected member of the National Academy of Medicine and an appointed member of the Federal Council on Graduate Medical Education. So it's a great privilege to have him here. He's got his finger on the pulse of the direction of healthcare and healthcare policy in our country, committed family physician, primary care doctor, and it's really a great privilege to have him here. So if you could welcome Dr. Bazemore.
Well, the privilege is 100% mine, and I am intrigued always to be presenting in places where I have, very limited, if any, street credibility. Because when you come from Washington, D.C. in an age of the swamp, it's actually a real privilege to be welcomed in South Dakota. And I know that you have a much more important visitor in our midst today from D.C. I'm hoping, as I heard this afternoon, that I can hitch a ride home on Air Force One if I'm lucky. And I should really tell you that no one's from D.C., and I don't know if my accent is still present enough to betray it. I'm from North Carolina. I came to medicine through global health interests, having wandered a very different path even in undergrad, and really have shaped my view of primary health care, PHC, through a broad lens, working on the ground in places like Honduras, where at the University of Cincinnati, I did work with Mark, in Bolivia, in South Africa and elsewhere, where broad team-based, community-centric care was a little closer to the norm than what we find in everyday practice here. I think that's some of what I want to share today. Let me tell you just for a minute a little more about what the Graham Center is. As Mark said, it is a division of the American Academy of Family Physicians, but a bit of a unique duck, like all of us are in family medicine. We don't look like any other association research shop. We were granted something by Robert Graham, who is still alive, who had been the head of one federal agency and returned after his AAFP time to another, something that he thought was uniquely important for a center like ours, and that was editorial independence. It really has by default become an agenda-setting independence, so we get to wade into all kinds of spaces, because when your charge is to study anything relevant to primary health care and policy, you've got a pretty broad door to walk through. And what we do, we're aiming to improve individual and population health delivery through generation of new knowledge, but also synthesis of knowledge. One of the things I enjoyed most in my joining the Graham Center out of the University of Cincinnati faculty was building mapping tools and geospatial analytic environments where you can go and play with your local residency program and see where your grads land or understand the context for population health around your center. So if it involves data and information that might drive better decision making, we would say that's policy relevant work, and we do it. The editorial independence, what it really means is the AFP gets to claim credit when it serves them best and distance themselves when it doesn't. We hope that serves as a win-win. And when we, under contract from the AFP, published a 2005 workforce report that went against all the other associations' reports that you needed more of us, and I said, no, you don't. You probably have enough of us. You just need to get more of us doing the things we're trained to do in the places where we're most needed and serving the population's interests best. That was not really popular. I can also say not everybody agrees with your findings, so when we came out and using some cost data and some utilization data, found that measures of comprehensiveness in family medicine could be created and related back to policy-relevant outcomes like lower costs and hospitalizations. I had laudatory and not always laudatory emails like the one that said, I challenge you to discuss this below in a public forum. And, true to my charge, I took him on. And I'm still here, and this is, in Hamiltonian times, this is how things work out in centers like ours. Point being, we hopefully provide an objective, evidence-based approach in all of our methods and our writings, and like to think that we're not just serving a singular tribe or singular purpose, but primary health care generally, or at least evidence that might inform it. I want to talk a little bit about definitions and origins. What is primary health care? Who's this Barbara Starfield, and what are her 4 C's that are definitionally important to many of us who work in this space? What are the other dimensions? Complexity, community, ecologies, and why are they relevant? And then try to, at least wherever I can throughout the talk, make it relevant locally. In an age of the patient-centered medical home, the accountable care organization, population health, and lots of other buzzwords, what does all this mean for South Dakota? Who is going to deliver this high-performing primary care, since we're in a training and pedagogic environment? And, again, what are the measurement issues in this space? And if I can do all that in the 45 minutes without being cut off, again, that will have been a big success. If we stop somewhere along the way, that's okay too. I did want to start with a little bit of context about where we are. I mean physically in this academic environment, the University of South Dakota, and somewhat of where it's come from. I'm a history poli-sci major, not a science major, and love looking backwards to understand where we are and where we're going. Does anyone know who Abraham Flexner is? I'll ask the folks in the room. See a few. I see Dan raising hand. Mark. Okay. So this is a really smart and interesting guy who a little over a century ago was given a charge to go out and look at U.S. medical education. And at the time, you can imagine, coming out of the frontier era, the 1800s, and into the much more modern industrial age, you had a lot of medical schools with a lot of different brands and a lot of different levels of, let's say, pedagogic integrity. And Flexner, again, in one of his quotes, proceeded to study these. And I'm going to borrow his own quote, "Science in the very act of solving problems creates more of them." What he did was remarkable and valuable and has created some, again, intangible long-term and some very tangible long-term consequences, not all of them positive for U.S. health and healthcare. He toured every med school in the U.S., at least every one that was known to him. He wrote a brutally honest, often scathing report. You should download this sometime. I can show you some quotes on South Dakota in a minute. He recommended that we take the 155 medical schools of the time down to 31. Remember, if you add up all the allopathic schools today, you're at about that 155 again. So this is how many he found. His vision for an ideal med school, and he only gave one school his real blessing, Johns Hopkins, the esteemed school that he visited first. His vision was full-time faculty, true affiliation with an established university, close association with and full access to a teaching hospital, increased emphasis on lab work, research, to be accompanied by state-of-the-art equipment and facilities, more rigorous standardized entry requirements, and so forth and so on. And when he came and reported on South Dakota, here's my picture of the early Vermilion campus. He certainly found a school that didn't get his most scathing report. He did say, and I'll refer back to this later, that it was unfortunately located and is producing a lot more docs than South Dakota needed. And this is back in 1910, when the physician to population ratios were actually much smaller than they are today. This is where you'll find that. I'll show you again later where the specific reference is, but he says specifically, I'll quote right here, protecting a people already supporting twice as many doctors as it needs. So he got very numeric in his calculation of oversupply. But in any event, a century later, he didn't get the schools down to 35, but he really kicked off a post-Flexnerian trend towards consolidation in what we know is the modern academic health center. And we sit in one today. And these are remarkable places that have done remarkable things principally through reductionism, reducing to the, again, the least studyable and most focal parts, elements of health, elements of organ systems, et cetera, et cetera. And these complexes are enormous, and they have, again, really put the U.S. in many ways at the forefront of biomedical science in the world. They've also had other consequences, and it's not just Flex Center, it's not just the Academic Health Center. They just get a particular and disproportionate share of the blame or responsibility here. Now, we know South Dakota for many things. I can speak as an outsider, not one who lives here. Very well known for agriculture, obviously tourism, even credit card industries. Less known, perhaps, when you start looking at employers, that 2 of the 3 largest employers, at least as of a few years ago, 2016, are right in our midst, Avera and Sanford. You're not alone in any way. When you look across the border to Minnesota, the number 1 employer is Mayo Clinic with 41,000 employees. In Iowa, and you can go look at this for any state, 5 of the top 10 are healthcare enterprises. In Nebraska, 5 of the top 7, and so forth and so on. And you look at this and you don't say there's inherently anything wrong or right about it, but it too has its own consequences. And when you look on a national scale, and I've probably used about 10 versions of this slide, if you go to the Chamber of Commerce or any other number of sites tracking job growth, tracking economic contributions of various sectors, you can look, and I like this window right here, at a window like 2007 to 2013, where we all know there was an economic downturn. And you can watch one industry, one area of the economy rocket right through it. That is a straight line with annual data points involved, with increasing job production and growth, while all other sectors of the economy had a very natural and understandable downturn. Now, my other favorite slide draws this out over about a 12-year period, and it was a 25% growth in jobs in the healthcare sector over the same period of time that you had only after a rebound, extending this line a couple of years, a 2% growth in any other sector. Fascinating. And so you start to say, well, what does that matter if it's producing something valuable and meaningful? Well, national healthcare expenditures, if you look at the annual Health Affairs Report, if anyone's looking for a good place to find them, which always lags about a year to contemporary reality. That's the only thing that we can study. But in 2017, our healthcare expenditures as a percent of GDP passed 18%, and the new projections are that they would rise, to about 20% by 2025. That alone is not only interesting, but starts to make you scratch your head about this enterprise, this industry of healthcare, and say, well, surely that has some consequences. Maybe that GM Ford bankruptcy that we saw and kept hearing might have had, in part, healthcare costs to blame for it. Maybe there are some downsides to this massive enterprise that we're all a part of. And where do we stand relative to other countries? Well, I think as many of you know, we continue to be an outlier in many ways. If you look at both growth and total spending, there is one line. You don't even need to see in this fairly busy slide with very small fonts. You don't need to see what's labeled. You just notice immediately that there's a red line that is nowhere close to all the other lines. Those are peer nations. And I don't care if you use the OECD 30, the Commonwealth 11 that tend to get rated against each other, or any other combination, we always stand out. And we stand out in other ways as well, because while we've generated a remarkable healthcare enterprise, we're not necessarily generating health. This is the Commonwealth cluster of countries. I could pull up the WHO and any number of other sources of ratings. But when you go rating the U.S. against peer nations, we don't have any peers in wealth per capita, actually. We are, at the front. There are some very small countries that pass us, but generally in purchasing power parity, we're at the top banana. But you look at what we're spending and what we're getting for it, and you get reports like these, or the wonderful National Academy of Medicine report that says shorter lives, poorer health. Pretty well summarizes its take on the last 50 years in U.S. pursuit of health. And about the only place that we perpetually rank 1 or 2 is in a category that some call responsiveness, or availability is one component of access, which really means if you have a card, insurance, and you have, or the wealth, and you have a need for some health service, your likelihood of being able to find it and get it here, that MRI, that service is pretty high. That does not necessarily mean that we're going to generate population health. As a matter of fact, by almost any indicator, it means that we aren't. We also are persistently rated as the healthcare system among OECD or wealthy nation peers, it is least equal, meaning that, again, with access to a card or financial means, your likelihood of staying in good health is actually pretty good here. But if you don't have those things, not so good. And it also has consequences for other sectors that we claim to value. I've used a lot of different variants for this slide. One takes 1955 to the present and just looks at defense, education, and health. Amazingly, defense actually is flatlined, even though we think we've been spending more and more, and just started to come back up in the wake of the Middle Eastern campaigns. Education has been going down for 50 years as a per capita spend, and a long straight line is healthcare. This shows it against Social Security, discretionary spending, other mandatory spending, i.e. the priorities that our state and federal houses have to wrestle with when they make their budgets. So as this begins to grow and grow and grow, it's competing out other important sectors to all of us. And your own homegrown Tom Daschle really helps me with a slide that I've used in my global health lectures quite a bit, which shows the U.S. healthcare spending pyramid versus, and that's on the right, versus on the left, perhaps what a rational designed pyramid might emphasize. As Senator Daschle, then Senator Daschle, said, other countries start at the base of the pyramid with primary care and they work their way up till the money runs out. And then he said, we have to change this pyramid. We really need to start at the base. So let's talk a little bit about ecology, another science not always necessarily thought of as one of the rationales for that statement by Senator Daschle. In the healthcare ecology, an ecology generally is a space in which, again, certain could be animals, plants, and others coexist and hopefully thrive. When you look at healthcare as an ecology, Kerr White, one of the fathers of health services research in 1961, using secondary data pulled from all sorts of disparate sources, was one of the first to coin this term and say, you know what, you can really look at a population, its utilization habits, and tell a lot about the behaviors of that population in a healthcare space he called an ecology. The Graham Center then, 40 years later, tried to reproduce his work with much richer modern data, including medical expenditure panel survey and other efforts to make it more nationally representative. And we found that, somewhat like Dr. White, that in an average month, if you had 1,000 people, you'd find that 800 would have symptoms of some sort. About 317 would consider seeking some kind of medical care. 217 might land in a physician's office, of which about half ended up in primary care. 65 would visit a complementary or alternative medicine provider. Remember, our data was probably poorest then there, and I would bet that number's a lot higher. 21 into a hospital-based clinic. 14 would reach home health. 13 an emergency room. About 8 would wind up in a hospital. And 1, or less than 1 actually, would end up in an academic health center, which is where we have dedicated considerable energy and enterprise to grow these massive campuses that look nothing like what was found at Vermilion by Dr. Flexner. And I've been asked, well, boy, that was 2001. Well, now you're 2018, so much has changed. Well, at least according to the Medical Expenditure Panel survey, which is nationally representative, looks at all non-institutionalized U.S. population members. When Johansson went back and repeated our study, I won't bore you with the rest of his slides, I'll just say that he created he and his team, a line of equivalent use and said, well, let's just go look at the last ecology study and the one before that and see whether the categories have really changed. And what he found was, nope, they hadn't. Almost all the little blue diamonds that you see there lie on the line of equivalent use. And his point was really this ecology, this environment of health-seeking behaviors has not changed that much. Now, obviously, in an age where you have a lot of these, and I'm holding up for those on the phone, my smartphone and telemedicine and other ways of accessing care, we're not fully accounting for those yet. But the general ecologies haven't changed. The central platform of delivery remains a primary care platform and something outside of this big academic health center where we all train, myself included, and continue training. And it has, again, some other interesting consequences. The U.S. is also an outlier, according to the pediatrician Barbara Starfield, who over 25 years evolved from a health services researcher not interested in this thing called primary care to one whose legacy is almost entirely built around it. Because the more she studied it in local systems, in insurance networks, in national studies, and in multinational comparisons, she found that we tended to be an outlier in our primary care-ness, and it tended to have negative health outcomes ranks. 38 studies, summarized well in a 2005 Milbank Quarterly article for those who are interested in reading more, found that whether you looked at cancer, at preventive outcomes, at cardiovascular outcomes, at mortality, or otherwise, places that had greater primary care-ness tended to have better outcomes. And they also tended to have lower expenditures per capita. These are associations, and they are ecologic. We'll talk a little more about what that means momentarily. So when you talk about high-performing primary care, would I stand up here today and say we're all surrounded by it? I'd love to, but I'd say it's not really an ecology or an environment in which that thrives. However, I would posit that places like the community that I'm sitting in right now are getting a lot closer to it than on some of the coasts and in some other areas of the country, and that there is something to aspire to. And you know, again, we want to really define what we're looking for when we talk about that foundation, that base of the pyramid. Is it something that only one tribe, let's say family medicine, general internal medicine, pediatrics, owns and can get to? Probably not. It's a function. It's got broad base. It absolutely involves more than just a doctor. If you go to 1978, we're in the 40th year, and a big celebration will happen in 2 months of this anniversary, of the Declaration of Alma Ata, where all the nations of the world, who convene about every 2 years under the World Health Assembly, organized by the World Health Organization, got together and made a declaration aimed at achieving health for all by the year 2000. When they made that declaration, they said this, that primary care is at the center of it all. It's essential health care. It's based on practical, scientifically sound, socially acceptable methods. It is made universally accessible to individuals and families in the community through their full participation at a cost that the community and country can afford. And again, it's an integral part of the country's health system, of which it is the central function and main focus, and over social economic development of the community. The U.S. Institute of Medicine, now the National Academies of Medicine, in 1996 adapted this for U.S. context. I won't read this entire one. I'll just say it said mostly the same type of language. It pointed out that clinicians would be accountable for addressing a large majority of personal health care needs. It would be about partnerships with patients. It would always be delivered in context with family and community. And it was the logical foundation of an effective healthcare system. And then, as I mentioned, we have been celebrating a lot through what we called Starfield Summits that the Graham Center has organized in the last few years, the legacy of a pediatrician at Johns Hopkins, Flexer's darling in 1910, who again created this mountain of evidence, but also defined a function. And what Starfield said the core 4 C's that define the primary care function were first contact. Patient can easily and regularly make first contact with this type of provider, she said physician, when an issue arises. It's based on continual relationships. It's based on coordinated care delivered comprehensively. That does not mean every last service delivered by this person, but most things able to be addressed. And what we've been trying to do in recent years at the Graham Center is not only study these 4 C's, but try to operationalize them, get out of the ecology and back to individuals, individual providers, individual patients. In an age of value-based payment, one of the important and imperative things that we need are ways to look at those 4 C's and try to make them make sense. I think in this state, and I've been talking to Dr. Huntington about the new rural training track and other, again, aspects of delivering to a very rural state, rural providers know the power of comprehensiveness. The academic health center has naturally been bred to reduce things to the lowest studyable part and the least common denominator of a deliverable service unit, and that makes so much sense if you're going to improve and rarefy and build on academic knowledge as a base. The thing that's potentially lost is the equally powerful generalist urge, and comprehensiveness is one of those 4 C's that really speaks to that. When I speak to comprehensive care, again, you can get into all sorts of dimensions. Are we talking about breadth Breadth of services, breadth of sites of service. We're talking about depth. Boy, you really know how to care for all the elements of your diabetic, hypertensive patient, and you minimize your referrals. Yes. Yes, somewhere in there is what we're talking about when we speak to comprehensiveness. And as I had mentioned earlier, just in the Medicaid population, although we're repeating it in other data sets now, we were able to demonstrate that, at least in family physicians, if you divided them into quintiles and you came up with one of 4 different rating scales by which we declared we could measure provider-level comprehensiveness, it was associated with important things like lower cost and fewer hospitalizations. We've moved on to continuity and have a paper coming out very soon. You take those same, again, 5 quintiles, and you look at the quintile that when I roll up any one of about 4 major continuity scores, this has been very well studied. We didn't have to reinvent continuity measures. Any one of 4 major measures of how well, at least in claims and utilization, we can track the regularity of contact between you and the patient that falls into your either declared or undeclared panel. If you look at the least continuous to the most continuous, you can get 13, maybe even 14% differences in patient total allowed charges in Medicare. We were getting about 15% differences in hospitalizations. We were getting, again, equal measure when you look at emergency visits. And again, this is using claims data, really a lousy way of capturing relational continuity, just a proxy at best for the number of touches you might have with a patient. And what we're needing in this age where value-based medicine is here to stay, and we are going to be asked to measure things, is how do we get less measures that microscopically look within the high-performing primary care domain at one aspect of one disease in which you can always demonstrate that if you do 5,000 of something, you will have some degree of statistically improved quality mark over someone who does 100 or 50 of them. But across all areas of care, you miss the mark perhaps on the big picture. Total costs, patient satisfaction, hospitalizations, ER visits. How do we get measures that start to tease out what Starfield said was important to primary care and make them a reality that can help drive high performance? Thomas Bodenheimer recently retired, but his legacy is certainly felt in the space of definitions of high-performing primary care. He posited that there were 10 real building blocks that started with engaged leadership. Primary care is going to perform at its highest. We have to be not only clinical technicians and experts, but we have to be leaders ourselves as physicians of teams and of community-based interactions. We have to have data-driven improvement, much as we all loathe our EHRs to some degree or another. We have to be regularly looking at our panel and understanding who we serve. We have to have partnerships between the patient and the team of delivery. We have to know our panels. We did a study of family physicians and found that only a third could even take a guess at their panel size. And the accuracy, only about half of them got it within about 100 patients being right. Guessing your catchment area, we just put a paper out this summer where we were showing the discrepancies between family physicians drawing circles on a map saying this is the community I serve and what utilization records actually demonstrated as their service area. We have to know more about who we're serving in a country where empanelment has not been the rule. We have to think about managing not just patients in those panels, but populations and communities. We've obviously been working a lot on prompt access. We have to think, again, back to moving 1 and what's labeled 4 on this pyramid together, about team-based care. We've already talked about continuity and comprehensiveness, and have to be moving towards templates of the future, said Bodenheimer. We also know that primary care is incredibly complex and that the payment model that we are hopefully moving slowly away from, pure fee-for-service, doesn't really serve it well. This is a simple little study, almost kind of a silly no-dust study, which are some of my favorites sometimes, where we just went and looked across, in one condition, diabetes, the complexity of ambulatory care visits of patients coming in for diabetes to specialty offices and primary care offices. And believe me, if you are a specialist caring for a diabetic who's incredibly complex, it is, again, very fair that you're reimbursed for the complexity of that care. However, what gets missed on the primary care side is where the patient measure may grade the complexity of the patient at a lower level than the average one for the endocrinologist. The average primary care visit includes the diabetic care and hypertension and depression and the acute 5 things they ask and the travel and the trip they're telling you they're taking a week before they go out the door, so that when you pay for the fee-for-service and you adjust more for the complexity of the patient than the visit itself, you're really missing something. Another lost feature is that primary care, as we mentioned, remains the main platform of delivery, even though only 31% of physicians in the U.S. are still in something we might label primary care. And I would go on that definition saying general internists, general pediatricians, those with med-peds degrees, family physicians. We can debate all day where other tribes, if you will, elements of gen psych, gen surg, OBGYN fit, but roughly 31% are in primary care spaces. But when you look, I don't care if it's the top 15 cost conditions from Medicare or the 14 priority conditions that the Agency for Healthcare Research and Quality puts out, when you look at where visit density lies, again, don't try to read on the left all these conditions which run from Alzheimer's to hypertension. The gestalt of this slide should show you that the darker bars on the right, which show the percentage of total visits in a single year in the U.S. for almost any of these conditions, still land in primary care. We can't get high performance to happen in those environments. We're missing our big opportunity to reach most of the patients for most of their care. We also know that this is increasingly the team sport that I've come to think of as intuitive in global health environments. When you ask family physicians in a survey that was, again, done as a part of the American Board of Family Medicine, therefore a census taking, we all had to fill this out to take our boards, do you work with? You find that the majority of them actually work with the nurse practitioners that they're simultaneously in scope battles with. That most of them are working with, again, physician assistants, well, not most, but a large chunk of them, starting to work with PharmDs and with other members of the tribe. This is an area that increasingly is intuitive in U.S. healthcare delivery, but it's not supported by the payment system. In my personal residency practice, we have a team despite itself. Because of Stark and non-referral laws, we have to be really careful about how we govern this behavior. But in our office environment, we're not, in a hospital. We've got a PharmD program with learners. We've got behaviorists who come in as independent contractors. There's a PT group that rents space on our hall. There's a radiology unit that is tied to a phlebotomy unit. We've got, again, a blended team of NPs, PAs, and family physicians. We've hired a cardiologist who comes in 2.5 days a week, and so forth and so on, all piecemealed together into our team, trying to figure out how to make that work in a fee-for-service environment. Not optimal high-performing primary care, but trying its best to get there. And if you look at the broader vision of primary health care envisioned at Alma Ata 40 years ago and heralded again this October, it really does, again, point to and encompass a leadership role for anyone working in the primary care space in population and community health. Virchow in most academic health centers is known for his triad that explains why blood clots fill some of our ICUs and our hospital halls. He's also one of the fathers of social medicine who really said, if medicine's going to accomplish its great task, it has to get out of the box and intervene in political and social life, point out the hindrances that impede normal social functioning of vital processes and affect their removal. We're hearing more and more about social determinants of health and that we need to be acting in those spaces as well, even while we're burned out of the ones we're already acting in. But what Virchow's really saying is we won't bend that not only cost curve, but upwardly tilt the health curve that we all pursue unless we get out of the office. And for primary care, this means revisiting old notions like community-oriented primary care. You see pictures of Sidney and Emily Kark, forefathers of this notion that if you're going to, in rural South Africa, in the age at the beginning of apartheid, care for a poor, mostly black African population with almost no resources, funding, etc., and you sit in the clinic and wait for things to walk in the door, you're not going to get very far, and you're not going to offer much. If, on the other hand, you put your hands in your pocket and you open your ears, and you engage through surveys and active data collection and conversations with the community and ask them what's the problem and how do we help solve them, you might get somewhere. And what Kark, I'd say, invented, really put on paper, and what on the right, Jack Geiger and others built into the start of what we know as the Community Health Center movement, our federal safety net in the U.S., was a COPC process that always had the involvement of the community at the center. It started with defining and characterizing the communities served, identifying health problems, developing interventions, monitoring their impact at every stage involving the community, and working in iterative cyclical fashions. And this has really been written up in almost any major report about primary care throughout the last century. The Dawson Report, that really first coined the term primary care. The revolutionary reports in the age of the birth of Social Security, Medicare, Medicaid, the community health centers that came out of Millis, Willard, and Folsom and birthed the new specialty known as family medicine. Lalonde's report in Canada. And from Folsom's report, this notion of communities of solution, and using the term borrowed from Watershed's problem shed, the notion you have to break down even natural political boundaries, because no city, no township, no state captures most health-related problem sheds, as he called them. And what Folsom's Blue Ribbon panel said was the primary care provider has a unique role that the other parts of community solution teams don't. The police, the school, parents, folks in social services, they really see across the public health, community, and medical domains in ways that can help solve these problems. We know that we have to do better at integrating something that is already integrated, mind and body, community health, and again, medical care. And we have to figure out ways in the primary health care environment, if it's going to be high performing, to not separate out our severely or even moderately mentally ill and send them some other place, but care for them in place. And why in an age where precision, again, a great adjective, has been fully captured in an important area, the study of the human genome, aren't we talking about precision primary health care? It's a lot lower hanging fruit with a lot less investment required to achieve meaningful dents in morbidity and mortality. We have geographic information systems, which Clark and John Snow and our forefathers didn't. We have incredible data sources. We've been working with Oregon and a national 3 million person database to add social determinant proxies, simple things, housing instability, poverty, education levels, onto every single patient captured in their study database, and even starting to push something we'd call community vital signs back into the electronic health record, so that whether you're caring for the patient or talking about your whole panel, you're seeing not just their average blood pressures or how many you have under a certain mark, but the degree to which you're caring for patients with profound social needs that you might be able to address. In the age of technology, this should be, again, a fairly intuitive thing going forward, though it really is a science that's having to be created on the fly, what you do about social determinants at the same time you're being asked to identify them. I've mentioned our mapping tools. If anyone's interested, I can gladly on the side steer you to our Health Landscape platform, to the American Board of Family Medicine's population health assessment tools, and many other technologies that are making this easier to access. At the policy level, this is a picture of a project that we ran with the state of North Carolina, which built on the backs of their data detailing architecture for all Medicaid deliverers, a geospatial technology unit. And what this really meant is you divided the state up into 14 geographies. You declared a medical director for each of the 14. And you took what the pharmaceutical companies have been doing well for years, a detailing model, going into the practice and saying, hey, did you know that this cluster of your patients had a whole bunch of ER visits for asthma last year? And actually, if you follow NHLBI guidelines in an ideal model, you shouldn't have any coming into the ERs. Oh, and by the way, using this mapping tool, we can show you where the smokers are most prevalent by county and census tract, where those NHLBI guidelines are least documented by practice and provider. We're not here to tell you what you're doing wrong so much as to help you try to get it right. And these are the kind of tools and technology that will drive high-performing primary care into the future. And again, when you look at my tribe, my clinical tribe, if you will, if there is one, family physicians, we're in a bit of an existential moment ourselves. 2004, studying the future of family medicine, there was a consensus that family medicine lacked an identity, needed to be identified by a singular basket of services that would include maternity, obstetrical, pediatric, inpatient care, and yet we could document in Graham Center study after another that certain elements of this comprehensiveness were waning. Pediatrics, inpatient, obstetrical services, maternity services, year by year. And so what primary health care looks like from a physician delivery standpoint, not just in one tribe, but in many, is really, it's in flux. This is one little slide showing a decline from 2000 to 2008, from 78% down to about 68% that were reporting any care of children. If you look at the general internist population, equally fascinating. This is a one-pager we'll put out in the fall. It's a simple little look using claims where we start to adjust for reported delivery of services and say, boy, if you pass either an 80 or a 90% threshold of your claims being reported from hospital services, you're probably not doing what we would traditionally call 4Cs primary care. And we'd probably say, at least by claims behaviors, you'd fall into that category of being a hospitalist. And if you look at generalists who are doing, and I'm sorry the colors didn't turn out well, I can see it much better on my screen here. If you look at those who are doing only outpatient, and we find those increasingly tribalized as geriatricians, or only hospital medicine versus those in the mix, you can project these two lines out and say there really won't be any traditional broader spectrum general internists left by about 2025. And most of the bottom category are starting to move more and more towards, again, non-specialty specialized behaviors like geriatrics. But does that mean we won't have enough providers? You know, we certainly have looked at this and we said, gosh, on the one hand, is it the best of times? You add up all the nurse practitioners and PAs using a co-location method, pair them with physicians that we call primary care, you've got a massive number of primary care providers out there. You've got a massive number of physicians. As a matter of fact, if you look at growth rate over time, 1980 forward, and this continues if you look at it in 2015, the physician to population ratio has just gone up and up and up, and it's only increasing. What you see is across these three lines, and again, I'm sorry the bottom one doesn't show up, the slope for primary care is the lowest. The specialty to population ratios have grown at the highest rate. You know, again, it leaves us with new projections where we come out and say, gosh, we need 52,000 new physicians if you're going to take baseline behaviors, care-seeking behaviors, add in the natural aging of the population, the natural growth, and this expansion of coverage under what's known as Obamacare. And you put them all together, well, we need 52,000 new primary care physicians to get there. But again, is it really a supply issue? Or is the bigger one maldistribution, poor composition, limited scope? And you start looking at states where, just take one element, provision of children, care of children in family medicine is starting to decline and say, well, this is a solvable problem. If you had different ways of paying, would you not take the training that was received and actually see it in practice? Would you be able to eliminate some of these gaps? When I look at South Dakota, any area in pink means we could not find in a PCSA, which is a HRSA definition of primary care service area, any child provider. Or in yellow, we were finding fewer than 1 per 3,000 population, certainly a federal definition of shortage. Couldn't we address this problem? So again, when you get to the training level, if you had a school that was located at the corner of a state, in which in modern times is doing an excellent job, by the way, compared to the nation at producing primary care, but still is adding small numbers proportionally to what it produces in the way of specialists, do you not have a fundamental issue in your training ecology match? We've created an online tool called the Med School Mapper using a large file and tracking every grad of every institution in the country. We've also done this for reports for groups like Ohio. I'll start picking on South Dakota for a moment, and I'll say, in Ohio, when we went to the Board of Regents and said, here are your 7 med schools, if you just want to look at geographical location and then a whole series of specialty outputs, you get very different answers as to the value to your state on those 2 accountability measures, which are rarely thought of, between 2 different institutions. Case is an unbelievable place. I did my tropical medicine training there. If you're looking for subspecialists working in mostly urban areas around the country, doing some incredibly rarefied work, it's an excellent producer. However, if you're a legislator saying, but I was really looking for more primary care, 54% of grads of Ohio University, the osteopathic university in Athens, and I want them to stay in state, we have a different view, a social accountability metric, if you will, and a different view of what might provide value for you. People forget that there's about $15 billion in total public investment in graduate medical education or residency education. But unlike England, with Health Education England and most other wealthy nations, we don't have a national workforce coordinating center. It's called for by a National Academy of Medicine report. It's been called for several times. But as Fitzmullen, esteemed pediatrician, ex-National Health Service Corps worker, and again, a national force in the policy space, said we really have an anencephalic workforce planning model. We hand out this $15 billion, and we say to the hospitals, go and create new residency training positions, and the hospitals very logically, operating under completely rational economic behavior, do exactly what you'd expect. You make more of the things that make the hospital engine run. And those tend to be avoiding cost centers and moving towards revenue centers. And that is not in any way unusual. That's very rational. But it comes from the top-level absence of policy levers. When we looked at an outcome study of grads that we could track, you need to go back, you need to have about a 7-10 year lag to really study where grads go. And we looked at the outputs of all GME. Primary care production rate's even lower than the current proportion of primary care visits. It's only about 1 in 4 physicians coming out into primary care. Only about 5% going into rural areas, even though the population is still 15 to 19% rural, depending on definition. You have 198 institutions producing, sponsoring institutions producing no rural that we could detect. 283 producing none that were going into federally qualified health centers, rural health clinics. Again, by social accountability, that's a problem. But let me try to wrap up here on a higher note. You have excellent opportunities here in South Dakota for many, many reasons to be leaders in high-performing primary care and healthcare delivery generally. You remain one of the top 20 producers of family medicine, and by last year's class outputs, it seems like that's only on the up and up. You guys know what another silly dust study means. I was asked repeatedly over years, hey, didn't you guys do a study on how many folks stay in state after graduation? We finally did it, and sure enough, it's about 50% of graduates stay within 100 miles of where they train in family medicine. So when you go and birth your new rural training track in Pierre, you start with pretty good odds of keeping folks in the center of the state where your gaps are in delivery. And you know that even though outcomes vary widely, this was we ranked every GME sponsoring institution in the country, and I'm showing you the bottom of the list of those who produce a lot of primary care and also a lot of rural. You have places you can point to. John Peter Smith in Texas, just a little south of here, is a remarkable institution. Again, it tends to produce broad-spectrum comprehensiveness who serve West Texas. There are models to look to. We know that if you touch safety nets, if you get in the community, if you train in place, the more you touch safety net settings, be it critical access hospital, a rural clinic, again, an urban or rural federally qualified health center, you find far greater return downstream, and we can track this into practice in those places. And again, these rural training tracks are of critical importance if they are of small size. Even the grads who don't end up in rural tend to have a remarkable impact on the places they land based on their low resource and, again, broadly comprehensive behavior. We're also finding in a series of imprinting studies that it's not only about access. When you train in a low-cost environment, when you train with a low-resource, choosing wisely mindset, you tend to practice that way for years. We call it imprinting, and it shows up in your claims behavior. Again, in conclusion, we're revisiting primary care on a global scale. Why not right here in South Dakota and in the U.S.? And I will end it there and say thank you, and hopefully left at least a few minutes for questions. Yes. Oh, great. I'll try to take them on. Yes. So it wasn't a patient measure, and I should get into some of the details of that. It was saying if you look at it gets really back to what happens in a primary care visit. It's rarely singular in focus. If you look at the percentage of all visits in which someone has cared for diabetes, most of those are happening in primary care. Most of those. Even though you'll find a whole cadre of specialists that touch that disease, most of the visits where you have that code happen in primary care. The point of the slide is not to diminish in any way the importance of non-primary care, as much as to say if you look at the platform again, the ecology, touches for diabetic patients continue to happen in the primary care space, even as the primary care provider pool, physician provider pool, diminishes proportionally year by year by year. I don't know that I can take that slide and really speak to efficiency. It does tell you about workforce. It certainly tells you that you have a, again, a small proportion of the total workforce having loads of touches, no matter which chronic disease, which seems to be the way we organize so much of our care in this country, no matter which one you pick. The majority of your touches happen in the primary care environment. If you can achieve high performance there, I see hope for bending cost curves, improving quality. If we can get to high performance there, you see real hope for a healthcare system that has a lot of spending without a lot of health. Sure, sure.
Isn't in the UK or Switzerland or any country that gets better results. Does that, in your view, indicate not so much the fact that policies exist, but they're misdirected?
So I love that you brought up the UK and Switzerland. Those are very different environments. I'm not one of the grass is always greener, every other country does it better speakers or proponents. I have traveled enough to know that the grass isn't always greener, but I've also seen enough to know that the lightning rod that the UK tends to be as a foil, as a socialist model, is probably equally under-nuanced. So let's go to Switzerland for a moment. Like Australia, like some other countries, you don't see heavy regulation. In Switzerland and Israel, for example, 4 major payers divide up responsibility, if you will, but operate privately in caring for most of the population. The delivery side is a private delivery side. And yet you're absolutely right. If you looked at the total volume of regulation, it's less. These are smaller places. It's hard to make direct comparisons. But what's been sorted out, and let's go to the Australian example, you divided hospital care into a national payment model, primary care into a state one. In each of these cases, you've created considerable administrative efficiencies, which we claim to get through our private model by saying payment really is going to be done by one unit. In the Swiss and Israeli examples, well, it's still private, but it's a pretty limited number with very limited administrative overhead and almost no profit taking. Those are areas where you have some real opportunity to bend the cost curve. But we're getting into a different lecture now. Yes?
Andrew, I want you to comment to his point, the rest of the world. So much of what we in primary care end up dealing with, and you mentioned the social determinants of health, the healthcare system gets saddled with the social issues that impact an individual's ability to participate in their care. And I would argue that other countries around the world have more robust social safety nets and social programming that takes that burden off of the healthcare system. And so much of the inefficiencies and the poor value, if you will, comes because we're just ill-equipped to manage all of those things in a primary care setting. And maybe a highly functioning primary care system has a component that takes care of and recognizes all of those social determinants. Because if you add all that cost together, I don't know that the gap between us and the rest of the world is as big. It's still there, but I wonder if it would be as big. And unfortunately, in this country, this is an editorial now. This is a red and a blue problem. And we are in a very red state that doesn't necessarily value all the things that need to happen in order for a highly functioning primary care system to be really effective. I'd just be curious of your comments.
So many. First of all, I think it's a great comment. I am also not one of the believers, even as we've worked so hard to raise awareness of social determinants in a high-performing primary care environment, to build tools that would enable the primary care provider to gain awareness. I am not in any way a believer that we now need to add one more thing to both our burden and to the total investment in the healthcare system, like addressing housing insufficiency, like addressing, fill in your social determinant. I think there's an awareness step. I think there are interventions we're not taking and could be, but I completely agree with you. This is in some way reflective of political cultural trends, of healthcare cultures, but also of the runaway. I'm going to focus less on the red-blue divide and say, when you have a runaway train like U.S. healthcare in terms of its per capita expense, it grows in both the resources it draws, the power that it holds, the potential areas it would like to now influence. I think some of what you're pointing out is, well, wait a minute, are we now going to take on one more thing away from other sectors that we've been bleeding dry for 50 years? Shouldn't the education sector and the housing sector maintain some of their control over these areas, if those are viable? Absolutely. I think what the health sector needs to do first is figure out ways to bend its cost curves and quit starving the other environments. And two, figure out how to be better informed about how to coordinate and align with, again, a public health sector that in this country is anemic, a community social services sector that is very anemic. And you're absolutely right. There's some choices. Getting back to your red state, blue state comment, I don't have problems with local. We're a big country of 320 million people. And if there's one thing that I'm saying comes out of a COPC model, it's solutions are often local. And you're going to find different states and different communities apply different approaches to problems. I think that primary health care, I think that our responsibility, speaking as a provider, is to make sure no matter which one of those communities you're in, red, blue, big, small, that you are looking outside the box, outside of your office, at least to have awareness of the social contextual factors that influence your patient's health. And no matter what you believe, on the most libertarian or the most socialist end of the spectrum, about your responsibility versus patient responsibility, that you at least realize that if you're going to achieve your goals, which as a physician or as any other form of medical training have to be aimed at health, not delivering a service, but at health, that these things influence your success. If you care about nothing else, you better figure out ways to bend that curve, an awareness curve. Even if you don't think you should be the one intervening, or if this is one more burden, you better be aware of your panel. You better be aware of the population that you ostensibly serve. Even if you say, no, my job is to see whatever comes in the door, you're not going to succeed at what you're trying to do. Is that the answer?
Yeah.
Yes.
We could go this all afternoon.
Yeah, absolutely. So,
One
but I'm
slide-
well aware of the burnout implications there. We study that too, yes.
One slide you showed on manpower included about 50 or so thousand advanced practice nurses.
Yes.
In that manpower model and perhaps in your conceptions here, are those independently practicing
Ooh, yes.
individuals?
So I hope in that slide I didn't weigh in on that one. I try to avoid it wherever possible. The scope debate is something that I, as a director of the Graham Center, have tried to not run away from, but steer clear of, mostly because I think it's a political debate. On the ground, we're all finding ways to work for health in teams, but then politically and usually over the crumbs they throw us in primary health care, we fight intensely over, again, who can work under what conditions. And interestingly, the primary care physician is caught. We were talking about this over lunch. We're stuck because we're in scope fights over whether or not to ease restrictions on independent nurse practitioners, pharmacists, PAs, behaviorists, and fighting for increased scope to do colonoscopies and obstetric deliveries with specialty colleagues who, interestingly, are also working with NPs and PAs to do most of the services. Primary care physicians really get squeezed in the middle. I don't know that I have an answer for you about what's right. I think that gets back to certain, in Alaska, where you have 3 NPs for every physician, it's hard to imagine anything but independent practice being their model. I'm not going to weigh in on right or wrong. It's just hard to rationally imagine. There are other places where that doesn't make as much sense. I think in most states that I've encountered, the reality on the ground is teams have figured it out and they're working together, and a lot of the fighting is at a high level. And when you create independent practice, you often don't change the environmental ground level that much. So I don't know what the answer is.
My question was not so much about the scope of practice issue, but whether or not, in looking at manpower, you were viewing those advanced practice nurses as independent practitioners, just like your physicians.
So
if they were, then your manpower numbers are...
Boy, now you can open another hour's discussion of when you model supply-demand curves. The most important one is not which member of the team has which authority to do what, it's panel size. Tom Bodenheimer and Kevin Grumbach say we can use teams to increase panel size. Others would say the future is getting smaller and smaller numbers of patients applied to physicians or providers or provider teams so that we can really do better care. And there's not a right or a wrong. There are places that have shown each can work. I think if you look at my slide on the best of times, I can make a pretty good case that we have plenty of providers right now. We're making so many nurse practitioners and PAs who come out with labels that look like primary care. There's actually probably not enough room to see a 10 and 20 year future for all of them in primary care. And I think you're going to really see a lot of the workforce modelers shift towards cautionary tales of oversupply. Some are already there before too long, in the same way we did in 1980. I think it's more important to figure out roles on a team. I don't know about South Dakota, but roles on a team, even in rural environments, than it is to sort out who can independently practice and who should be governed and supervised. Because we all have different skills and training. We do different things better than others, and I think that's probably the future of the team more than who gets to independently practice. And I don't think, back to your original question, I don't think we're lacking total numbers in most places. South Dakota's one of the places I would say could be. In most places in the country, we're lacking the ability to do what we're all trained to do at the fullest extent of our training in primary care, much more than we are lacking in numbers.
Cool. Thank you so
Thanks,
much.
Mark.
Appreciate the engagement and discussion. For the sake of those teleconferencing in and those who have to be elsewhere, we're going to wrap up Grand Rounds now, but I'm sure Dr. Bazemore will be around for a few minutes to further discuss any issues of interest. So, again, thanks so much.